All right, Cass. I know we've talked a little bit before, but still, like, can you introduce yourself a little bit for the audience?
Of course. So, yeah, my name's Cass. I'm a physiotherapist here in Calgary, Alberta, which is in Canada. I currently work out of two clinics. So, one is called Orca Performance, and then the other is called Absolute Performance Center. In addition to that, I work with one of our national teams. So, I'm currently with Volleyball Canada, slotted with our men's sitting volleyball team. And then I also am a medical director for a youth volleyball team here in Calgary. So we have a lot of high performance youth athletes that end up going on to kind of CIS, NCAA, that kind of thing, moving towards college. So lots of volleyball in my clinic, that's for sure.
Nice, nice. So, um, like our topic, the main topic today would be like surrounded by like Achilles tendon,
Mhm.
and there's a lot like there's more and more Achilles tendon rupture or like tendinopathy, whatever it is, in like whatever level the sport is. So, what got you into like doing a lot of Achilles tendon at the first place?
Yeah. I actually started doing more like foot and ankle kind of specialty, if you will, just a couple years out of my physiotherapy degree. And I actually did that because I hated treating feet. I thought it was something in physio school that was kind of just glazed over. We didn't get a ton of info on it. And I always felt very ill-equipped whenever someone with foot or ankle or calf pain came into the clinic. And so rather than be stumped by it, I kind of just dove in head first and started taking some more integrated foot ankle courses. And from there, just naturally, I think started seeing more and more foot and ankle injuries in clinic. But yeah, over the last kind of 12 to 16 months, I actually kind of went back and counted. I had over 30 Achilles ruptures this year in clinic. So had a lot. And some were, seeing me from day one. Some were referred to me kind of later on in the process if it wasn't going well or they had known. This is kind of something I see a lot of in clinic. So I've definitely seen a variety from day one surgery or non-op to like they're actually already a year out and they're just trying to get back to where they were recreationally or through sports. So definitely a wide variety and lots of different case studies to pull from.
Hmm. So
Mhm.
I guess my next question would be like, what do you think that is that's like causing like there's more and more like these like soft tissue injury, Achilles tendon injury, or like plant, what is it called? Forgot.
That's
Whatever. But
okay.
yeah,
Like the
Achilles,
mechanism.
like why
Yeah.
is there like more and more Achilles tendon issue?
You know what? It's such an interesting topic because I think we don't know. And if I'm going to be completely honest with, if we took those kind of 30 case studies from the last year alone, there's really no common age demographic, there's no common sport. None of them had existing pain or issues with their calf ankle complex prior to this. The only kind of commonality was just the mechanism, which was that kind of what we call the false step or plyometric step, where there was that forced dorsiflexion with anterior tibial excursion. So aside from the mechanism, it was really hard to pinpoint clinically like what was a common cause. And like there were definitely some patients that maybe weren't super strong, don't necessarily keep up with proper strength and conditioning, and then jump into really high demand activities. Like some were just picking up a volleyball game or a basketball game and don't necessarily jump outside of their day-to-day routine. So those ones would maybe make a little bit more sense when we're looking at capacity versus demand. However, some of my tactical athletes, like some of my pro athletes, these guys are in the best shape you could argue that they've ever been in. And yet it happened. And some of them, I don't think any of them had any pain or symptoms in that Achilles prior to this. So I think it's something, I mean, I'm going to keep an eye on it in the literature if we can kind of come up with why is this so prevalent over the last few years? Really hard to say. If I had an answer, that would be great because then I could start telling people. But more so, I think we're just trying to keep tabs on, again, are there any kind of occurrences that are happening outside that common mechanism? But right now, I can safely say that's kind of the number one cause is just that kind of false step that we see so often.
Nice, nice. So, uh, I guess the the following question would be like ACL, like there's probably a lot of like people are really familiar with ACL return to play.
Mhm.
So what makes Achilles tendon like return to play like harder?
It's much more variable, I think would be a good way to describe it. I think, I mean, at least in my experience too, um, there's a lot of different protocols that exist. And I think there's a lot of different ways that we can rehab from, that dative mechanism to, whatever that return is, whether it's more recreational or professional in nature. So not only are there a lot of different protocols, but even within that literature, the time it takes for patients to achieve some of these basic benchmarks varies so wildly. And it's really hard to predict kind of why that is. One of the kind of basic benchmarks that we use is the ability to achieve kind of 5 to 10 heel rises to kind of maximal height. Hopefully by month 3 would be kind of one of my benchmarks, but only 50% of people have been reported to actually achieve that at that timeline. And that's even with patients who are doing the exact same protocols as those who do achieve it. So I think it's just, one of those etiologies that we're still not quite sure and we're trying to piece that out. The good news is when you kind of do look at some of these really well thought out return to play protocols with some of the benchmarks that we've pieced together, I think we're starting to see more consistent timelines, which is great. But something we can chat about probably later on is that I have athletes who go back to kind of performance, if you will, around that 5 to 6 month mark. And I also have athletes who don't make it until closer to 18. Like it's so long and kind of drawn out. And I think I'm going to have to turn that on silent. Sorry. I think it's one of those things too where we're a lot more kind of benchmark focused and we're trying to get really good objective data so that we're not guessing on whether or not, is this ready to go back or is it something that we're going to be really sure about? So I think introduction of some of these, newer technologies like force plates and force frames. I'm a valid girl, so I use a lot of the valid tech. Super, super helpful in just making sure we're on the right track. And obviously on my end, I'm getting a lot of data on kind of what does that timeline look like, which is helpful.
Nice, nice.
Yeah.
So I'm gonna start by asking because before I reach out to you, uh,
Mm.
I did a lot of like research on the protocol for a consistent return play.
Yeah.
And the past summer, I actually helped a few basketball player return to play from Achilles tendon rupture, but it
Amazing.
just varies a lot,
Yeah.
right? If you like Google Achilles tendon rupture return to play or return to performance, some of them would start partial weight bearing like after 6 or even 10 weeks, but some
Hmm.
of them start at like week 2.
Yes.
So, talk to me about like your protocol from like for the return to play.
Yeah, I think a lot of that too, and it might be dependent on kind of where you are in the world and kind of what that oversight looks like from, medical assist, like what medical staff or surgical staff. For us in Canada, like a lot of my Achilles repairs that were surgical is you really are working with that surgeon, kind of what type of repair did they do, what's their inclination, and how kind of protected do they want to keep that repair site and for how long. So I'm lucky I've got a couple really awesome surgeons up here who kind of trust this protocol that we've built together. So ours were usually, for this kind of more accelerated protocol, and accelerated meaning I think it might be some kind of misleading. I think a lot of people assume that it gets you back to sports sooner, when in fact it's more we're just getting you weight bearing sooner, just because we know the effects of weight bearing on that repair can be much more beneficial. We're starting to see the effects of, decreased tendon elongation, better strength, earlier time to kind of a proper heel rise, those types of metrics. Not necessarily performance sooner, but we all know the benefits of early mobilization. So with ours, typically this last one I did, you're usually in some form of like a cam boot or with a 20 to 30 degrees of plantar flexion kind of block. Usually non-weight bearing for about a minimum 2 weeks. Sometimes it's earlier if the surgeon's like, nope, this is good, and I'm happy with this around 7 to 10. They can get you feather weight bearing, partial weight bearing. The one I did this past summer with one of our surgeons, I think we had her walking around 2 weeks in a boot in that plantar flexion block. But we basically transitioned her, I think, to fully weight bearing around 6 to 8 weeks. That was in a boot still, but she had like no restrictions or pain or concerns around tendon elongation at that point, which was pretty awesome. So again, but then that was kind of one of my tennis players. And then I looked at, my one of my tactical athletes who had the exact same surgery and the exact same kind of mechanism, if you will. And he was fully non-weight bearing as per the surgeon's request for 6 weeks. So, those were just, I look at their outcomes and their timelines towards the end were fairly similar, but those initial kind of 6 weeks were very different. And I think for me, where I am in the world, a lot of that does depend on the surgical team and just kind of maybe the repair they did and some of the studies they're seeing from their end, which is obviously a little bit on my end, out of my hands. But I get to work with them. And hopefully, if we're seeing some of these targets that we want to see early on, like, are we a bit more confident than moving them to even just partial weight bearing?
Nice, nice. So
Yeah.
I'm looking at the protocol you sent me right now.
Mm,
So uh on the 0 to 2 weeks, there's an open chain
mm.
knee and hip extension drill. It's a Achilles tendon rupture. Why do we need to do knee and hip extension drill?
Great question. I love to like reverse engineer and try and do as much as we can early on when we're limited at the physical, injury site. So, hip extension, knee extension are two movements that you can do that don't necessarily in an open chain position stress the Achilles site. But these are movements and postures that we are absolutely going to want to see later on. So if you can work on those now, why not? Right. And I think that's one of those things we also know is even with a fully repaired Achilles tendon, whether it was surgical or non surgical, we know the knee, and there's been studies that show the knee ends up taking on a lot more of that load, regardless of the repair and how well it rehabbed. So if we can kind of prep some of those positions proximal to the chain, why not? And I think in my experience, it's transitioned us into some of those kind of upright running postures, those acceleration postures a lot more smoothly, just because they're not as, unfamiliar with that posture, having not been in it for, up to 6 weeks, 8 weeks, or sometimes longer. So those are ones I like to do. And it just keeps the rehab a little bit less boring because when we can't really do a ton at the surgery site and we're kind of limited to more just like toe and scar mobility, it can get a little bit boring. So I always try to keep them engaged and work up the chain as much as I can. And a lot of my pro and tactical athletes, like they're doing full upper body days, whether they're just in seated or slightly different positions so that they're not load bearing. Again, just try to keep them engaged as possible.
Nice. What about there's another thing I didn't see a lot on the return to play protocol for a Cassandra rupture is foot and toe mobility. Why do you put foot and toe mobility in there?
Yeah, again, if you look at some of the recent research around kind of Achilles tendon like ruptures and repairs, a lot of us are looking at kind of some of those accessory movements like your flexor hallucis longus, and what is the capacity of even that big toe, and it's important in some of those toe off positions. So, its proximity to the Achilles tendon, the fact that it's also a plantar flexor, we want to make sure that we're able to utilize these, but we also want to be cognizant of possible compensation patterns. So I've also had patients come refer to me at 3 or 4 months and they're still unable to do a calf raise at that point. Well, sometimes it's because that Achilles tendon itself is not actually contracting and they're trying to utilize some of their other smaller plantar flexors, which, as we know, are not nearly as efficient at propelling that heel off the ground as our Achilles would be. So it's nice for, I find, patients to have the awareness of kind of, okay, what does toe and more intrinsic foot strength look like? And how does that differ from when we actually want to, contract and utilize that Achilles? And I just, again, find it translates a little bit smoother into those phases where we can start loading through that triceps area a little bit more. And again, it's just one more thing we can do in those first few weeks so they don't feel like they're just sitting at home waiting.
Nice, nice.
Mm.
All right. So after the 0 to 2 week, from we after like from week 2, you start like gait retraining, right? And
Mhm.
on the goals, you also mentioned that there's a backward step, walking backwards or sideways. Why backwards and sideways?
Yeah, again, it kind of is context dependent on, again, so some of my cases, they were like no load bearing until 6 weeks. So this would be kind of one of those timelines that you push. But in this accelerated model that I've kind of utilized in the past couple of months, when we're cleared at 2 weeks to begin even partial weight bearing, so we have some form of crutches or gait aid, we just want to restore some of those postures as quickly as we can. And if that's even at 30%, weight bearing, if that's at 50%, we utilize as much as we can, obviously with gait aids, but there's slightly different ways to basically achieve the same goal. So is sidewards, or sideways walking, it might feel a lot less load specifically on that posterior calf. So we can utilize it and still train some of the muscles up at the hip or the trunk, right? Backwards walking, that's another way that we can kind of get a little bit more a little bit more range at the ankle, a little bit more movement. Again, constant context dependent based on what phase you're at and kind of how much plantar flexion you're allowed. But usually it's very little steps and it's just another way to train up the chain in slightly different muscle groups than going forwards. So I do a lot of just different styles of gait, different ways of gait. Sometimes we're on treadmills, sometimes we're not, sometimes we're just on turf. Gait aids, no gait aids. But I always find like the more we can get them walking with proper, I'll use the term posture. I often find the transition out of the boot is just so much smoother. So we have kind of, a way where we're just making sure we're getting proper, proper hip flexor action. We want to make sure we're confident with a bit of a heel strike. What's that transfer to kind of stance or mid stance look like? Toe off is usually a little bit artificial when you're in a boot just because you're kind of locked there, but it's more so I'm cueing, patients, can they get that at their knee, can they get that at their hip, and what does that extension look like? If we have to kind of modify around the ankle if you're in a cam boot, so doable. You just kind of cue at the knee or the hip or the trunk, and then once we're out of that cam boot and we have a lot more of that freedom of movement is where we can kind of almost revert back to, okay, gait foundations level 1, and let's make sure that your ankle is actually tying into that as well as your knee and your hip and your trunk.
Nice, nice, nice.
Yeah.
So, uh, I guess there's like, I think there's a not really a problem or like question, but like people introduce isometric into like Achilles tendon return to play. Like the isometric part, they like it differs a lot. Some people like introduce isometric very early. Some
Mhm.
people do isometric like probably start very, very late, or they don't even do isometric. So what about your thoughts on like introducing isometric into like Achilles tendon return to play?
Totally. I definitely utilize it. I don't know if I have just like, one specific metric or protocol around isometrics that I only use. But I think a lot of my kind of tendon specific knowledge has actually come from Jake Tra. I'm sure you've heard of him online. He's kind of like the tendon guru. But some of his work, as well as some of like Jill Cook's work on just Achilles tendons specifically, and how they kind of remodel and adapt. Isometrics are not only a great way to present load, but they're also great for pain kind of inhibition and helping to target some of the issues we see with just symptoms like pain. So I find them also to be a relatively easy way to introduce load that you can really easily control, if that makes sense. Like it's really up to the patient to just exert just as much force as you're capable in kind of X position. And almost all of them are a lot more comfortable loading in an isometric fashion compared to a concentric fashion. And I'm definitely not adding eccentric for the first little while after an Achilles repair. But so I wouldn't say I think they have a place throughout. I think it kind of also depends on your intent. Like what is it like a max effort? Okay, well maybe that's not got a place in the very beginning, but it absolutely has a place probably later on as you are kind of gauging a true return to play. And there's a lot of different metrics we can hash out from some of the calf specific ISO tests that exist. But yeah, I know for the one protocol I developed with one of our surgeons, like I was doing isometric testing, kind of using the force frame app with Vald from like week 2. So basically, just had them in a seated plantar flex position. I still had their heel wedges in just so that we weren't coming from neutral. And I just had a percentage of their body weight that somewhat correlated to their basically their body weight while walking restrictions. And I just compared it to their non-operative side and we trained them at like 3 times a week. So it's a great way to introduce. And, I think what I've talked and mentored a lot of other physios on, a common issue with Achilles repairs, or even if they're non-operative ones, is that fear of re-rupture is massive. And I don't know why, and maybe this is just my experience, but isometrics are such a great way to just introduce loading to some capacity because we know the tendon needs load to heal and to remodel. And it's a great entry level kind of way to do so. And so, me personally, I think they'll always have a place. I think we just have to be very cognizant of, again, like what's the intent? How are you progressing them? What is their role at that point in time? And does it match kind of those specific demands you're looking for? And if it doesn't, then maybe that's a good time to evaluate whether or not they belong. But I definitely use them early stage, and then I definitely use them as like an end stage return to play testing metric. Like I have a benchmark that we use from the calf ISO push, and we look at not only the peak force but also like the rate of force development as well. So I think they're valuable.
Nice, nice. So, uh, since you introduce gate, since like the accelerated protocol, you introduce gate like really early and isometric really early, does that mean that you're able to probably introduce plyometrics, maybe just a little bit and very low intensity plyometric, very like also very early?
Yeah, I think for me, with the one case study that we kind of utilize this on, in addition to some of the research that supports it, we're not necessarily adding it earlier. I wouldn't say that I'm necessarily adding it. Um, oh, I guess early. I guess it's hard to say. I think what I would describe it as is that by the time they're able to do plyometrics, they're in a much better place to be doing them from just like a strength capacity standpoint. Kind of some of the benchmarks we've looked at that ankle and the repair itself, just because we've been loading it earlier and they have more time to load it. So I think that also kind of similar to ACLs, we kind of go back to that old timeline approach versus a more functional approach that uses, objective benchmark testing and, what do we need to see and why. So I think that kind of ties into that a little bit, is that in theory, in an earlier mobilization protocol or accelerated protocol, you've been loading it for longer and hopefully with less issue. And if you're progressing it well, I think that plyometric kind of introduction on a best case scenario, like I haven't seen earlier than 4 to 5 months, and even then, like it's in a very very like low amplitude, gentle kind of just things like pogos or your easy scissors, like those types of things, whether they're assisted or unassisted, shuttle presses, Pilates reformers, those types of things. And again, like as I kind of mentioned in my protocol, we have benchmark tests that you kind of have to achieve before we even consider putting a patient in that position. But again, like I wouldn't say that an accelerated protocol necessarily gets you back any sooner. And again, like I'm not a researcher, these aren't like necessarily, these are just more case studies, but I can say with confidence that we're loading the Achilles with a lot more confidence. We're doing it earlier on, and those results long term kind of favor a less likelihood of re-rupture, less likelihood of that kind of longer elongation of the tendon, and a higher cross-sectional area, which obviously favors a lot of the things we've been talking about. So that's kind of, I think, where I'm at as well with this protocol I've developed is I just have a lot more confidence as we move through these benchmarks that that tendon's in a really good place versus, not having load bared through it for so long in the beginning. It's like, okay, where is this tendon with respect to load? Is it going to take longer? It might not, but I just find my confidence a lot higher with it. And hopefully that's the whole point of a lot of the research as well. Just gives
Great,
us a little bit more confidence in our ability to load these sooner, obviously with caution. But
great. So,
mm,
uh, another question about like Achilles tendon return play is, I know some practitioner which will start like mobilizing their foot or like try to increase their dorsiflexion angle early or like
mhm.
mid stage. And I know some of them probably don't like to do that. So what are your thoughts on like increasing dorsiflexion angle?
Totally. Um, I, yeah, it's a good question. I think it's interesting when I look back on some of the ones I did this past year. Again, some of them are coming to me at 4 or 5 months and still can't do a heel raise, right? And, some of that was they had very limited dorsiflexion angle, barely past neutral. Some come to me out of the boot and their resting plantar flexion angle is like way too small. You're like, okay, that's actually already looking a little long. And I think maybe a little context specific, but one of the tests I use is just like a resting plantar flexion angle. So the patient's kind of lying in prone with their knee bent to 90 degrees, and you kind of just let the ankle relax and you just measure kind of that angle relative to the floor, kind of what that plantar flexion angle or tone is looking like. And I always compare to the non-op side. And so studies have actually shown that that stabilizes after a repair between 3 to 6 months. So I'm not doing a ton of, dorsiflexion specific work, prior to that 3 month mark, beyond just getting the patient kind of ambulating well, working on that strength from neutral kind of at my kind of low, or that would be like kind of the most I'd be pulling from. I'm not working too much on deficit work from neutral at 3 months. But once I hit 3 months, I'm a little bit more confident if we're still lacking range, which most of the time we are. I'm a bit more confident to start working on it there. If I am working on joint specific range prior to that, I'm really just putting kind of that tissue on slack, right? So I might put them in a little bit more of a plantar flexion or neutral position. And then I might work specifically on that talus and just do more of like a posterior glide, working on just some very, very gentle soft tissue through the back, but not asking that ankle to go into any more dorsiflexion than they might have. And honestly, I find that that's enough. Sometimes, yes, that talocrural joint can be really bloody stiff from having been in plantar flexion for so long. And so that's where some of those posterior glides can be really, really valuable. But it's not one of those things that I am just pushing 3 months out. I'm like, my philosophy, and I'm not saying it's necessarily right, but I would much rather have a super stiff ankle with a really solid tendon that I can work on later than, have this surgically repaired tendon that's elongated beyond, fixing conservatively. And I think a lot of the surgeons agree. So my approach to achieving dorsiflexion range is a little bit more conservative. I'm going to look a little bit more to some of just those functional postures and patterns. Can they achieve those? Is that motor control where we want it to be? Does it look good? Is it functional? Is it pain free? Those kind of things. And then once I kind of start hitting that 3 to 6 month mark, and I've noted that plantar flexion angle has stabilized week over week, that's when I start to hit the range a little bit heavier. And that's usually produced pretty good results.
Cool, cool. So,
Mhm.
uh, because I know there's debate about like if you introduce like plantar flexion really early on, that's going to increase the risk of re-rupture. Some like I know some physical therapists would say that. Because I was actually talking to another physical therapist in Taiwan. He said like, yeah, he's not probably not gonna do that very early on. He said like probably weight bearing or partial weight bearing will increase some of the dorsiflexion angle. And he
Mhm.
said early on that's already enough.
Yeah. And I think and I'm sure different physios, different researchers, different surgeons are going to have, their opinions. It's just for me, I think when you look at what you're trying to achieve, what's the number one thing we're trying, especially, conservatively if they're in a boot versus surgically, we want to avoid tendon elongation, excess in excess, right? And I think some of the metrics we're pulling from the research is anything kind of above 3 centimeters compared to the non-op side is considered long, and can then translate to poor outcomes, higher re-rupture risks, or inability to achieve that kind of or desired heel height symmetry. Um, so yeah, it's not something I'm harping patients on. I'm not like, 2 weeks out of the boot, you got to be to neutral. It's like, no, this will come. And the way I kind of describe it is like we can achieve, dorsiflexion neutral at 6 months if we had to. It might be a lot harder at that point in time if we've had to be super conservative up until that point. But I can't make the tendon any shorter, but I can definitely work on a stiff ankle. So I think that's the approach I kind of take. And obviously, if we need to utilize different medical assistance, whether that's, physiatry for injections or, surgeons for debridements or surgeons for second look, like great, we can go down that route. I've only really had, I think, one or two of my pro athletes who've had to have different types of injections because we were struggling with certain benchmarks and range. But that was well past 3 months. So it wasn't something that I was too concerned about prior to that.
Nice, nice. So
Mm-hmm.
I know a lot of like return to play protocol, no matter it's like Achilles tendon, ACL, or like hamstring strain. A lot of them like what happened at the end is like the injury limb is probably stronger than the non-injured limb. So
Mm-hmm.
what happens after that?
Um, that's interesting. So I don't know if I've necessarily seen that per se, and maybe it's because I'm anything that the injured side is doing, the non-injured side is doing, and I always monitor both. Especially I think with we know the amount of compensations that can happen at the knee or the hip after an injury like this. Like we want to make sure not only on that ipsilateral side we're taking care of some of those possible deficits, but the contralateral side could face some sort of compensation as well. So our treatment approach, especially at Orca, is just it's super comprehensive, full body. Like we're not just treating like that one Achilles, like we're kind of treating, the whole body, because what is it going to look like when we get you back to training? Because that risk of, other injuries could be quite high if we're not careful. So I don't know if any of my cases have necessarily been stronger. I think obviously there's a lot more attention to detail and kind of effort and awareness around the surgical side, which would be expected. But we're pretty good at just making sure we don't ignore the other side or the other what's going on up the chain or below the chain. I think what's interesting about Achilles is it's actually, I think, in my opinion and my experience, is one of the harder injuries to come back from and achieve that true limb symmetry index, whether that's looking at force or just girth. One of my pro football athletes right now, like he ruptured his Achilles tendon 2 years ago, and we still don't have the same girth as the other side. Now, all of his metrics are the same, kind of, or what we would consider equivalent side to side in some of our return to play testing metrics. But the girth is still different, even though the injury was 2 years ago. And will he ever achieve that back? I don't know. But we're quite satisfied with the criteria he's met that he's not at risk of re-rupture at this point in time. So we're confident with that one, but it's not something that is uncommon in the literature, and that limb symmetry index is a lot harder to achieve after an Achilles rupture in the calf. And again, not sure why. I think that's maybe a little bit above me and kind of what I see in clinic, but it's definitely something we do see. It's something that takes a lot longer to come back.
Hmm. So in
Mhm.
our conversation, you mentioned a lot of like below, sorry, up, go upper the chain or lower the chain, or you mentioned a lot of times about asymmetry. Why you mentioned these like so many times? Like, why is this so important?
Yeah, I think especially in the context of our professional athletes, like you can't really look at some of these injuries in isolation. In the beginning, you can absolutely, just because the focus is going to be on that repair site and making sure that it heals fundamentally well. But once you're getting back into your return to training or return to sport movements, like it's no longer just a calf, right? What's going on at the knee? What's going on at the hip? What's going on at the trunk? When you break down some of those movements, one of my favorite courses that I've taken the last year is actually Alan Murdoch's Fast Over Fit or Fast Fit course. And he kind of breaks down something as, running as simple into kind of what he calls high amplitude actions or high impact actions, I think they're called. Basically, your max speed, your acceleration, your deceleration, and your change of direction. And you can very simply kind of break it into what is the trunk doing, what is the hip doing, what is the knee doing, what is the ankle doing. And I think it's such a simple, beautiful way to kind of realize like, sure, you might be rehabbing an Achilles, but what is everything else doing and how might it compensate if we're dealing with some sort of a longer term injury, right? That we're rehabbing for months on end. So I think it's just, a really important kind of not lesson, but just reminder that yes, we're looking at an isolated body part, but if we're truly rehabbing to a return to sport or performance or whatever that might be, like you can't look at it in isolation. And I think, context will differ based on if it's an Achilles versus an ACL versus, like a hip labrum coming back, like those types of things. Like they're all going to have slightly different nuances on how might this affect what's going on above or below. But I think as long as you're aware of that, and remembering that those pieces still have a part of the full rehab picture, um, your athlete or your patient's going to be in really good hands. So that's the way I try to frame it. And yes, that Achilles is probably going to get most of my attention, but you're going to have to look at everything else to make sure you're not missing anything.
Awesome, awesome.
Mhm.
So I guess I'm going to the sexy part of return to play. Is like benchmark you mentioned, or like the technology, or like the testing, like people like to talk about. So,
Yeah.
uh, what kind of tests would you do from like time to time, or like decide like uh we should move on to next phase?
Yeah, so I think kind of in the document I shared with you, the ones in the beginning are a lot more functional. Like if you have access to tech, that's a bonus. Like you can do things as simple as like quiet stand, what's your weight bearing symmetry look like? You can do a squat assessment. You can look at depth. Are they willing to load? That's going to be a reflection of their willingness to go into dorsiflexion. Like you can do those things and I do use them, but I think the big benchmark tests really are going to be I use gait as a big one. Like, does their gait look normal? Can they achieve the necessary range and position to walk normally? Because everybody has to walk. So that's, I think, kind of my number one priority. I think, as I shared with you, kind of in that like out of the inflammatory into that tissue reintegration phase. Um, the big kind of benchmark that's supported in the literature as well is achieving 50% of your body weight with like a seated calf raise. So that's obviously adding external load to kind of the knee if you're in a 90-90 position from neutral, and just can you achieve 50% of your body weight in a calf raise in that position. So that's one that's utilized a lot. And then kind of once you're able to do that, I'm a lot more confident with that a tendon to start taking and absorbing and kind of withstanding load. And so from there, the next benchmarks I usually use are a little bit more functional. So I believe one of them is like, can we do 5 single leg calf raises to 90% of your available heel height? And that's kind of an important caveat because you don't always get 100% compared to the non-op side after a repair, especially before 3 months. So if, let's say, their available range is 10 centimeters from the floor, they need to be able to do 5 to 9 centimeters before you can progress them into some more of those looking at speed and power and endurance phases where I start to get a little bit, like you said, more sexy on the plates. So they're very basic benchmark tests. And the nice part is you don't need fancy equipment to be able to use them. Which is really awesome, and they're very well documented in the literature as well, that correlate to kind of lower re-rupture risks, lower rate of tendon elongation, those types of things. So if you even just use those ones alone, I think you're off to a great start. But if a patient can achieve those 5 single leg calf raises to that 90% of their heel height, that's when we start introducing some of those more, you might call them plyometric type exercises. So I do a lot of little like calf raise, like rebounds. So they're just kind of increasing the rate of their loading. We might look at things like assisted pogos or use of like a shuttle press or like a Pilates reformer. So it's not full body weight, but we can start to play around with the rate of loading through that calf complex, those types of things. So that's kind of where I start. And then once I move into more of like, let's utilize our force plates and actually get a really good gauge on where this tendon is, that's where we start looking at, I like to use like the ankle iso push, like the Alex Natera one, as well as the knee. So I use the ankle specifically to look at the ankle peak force as well as the rate of force development. So I usually look at the force at 100 milliseconds, as well as the peak force for that test. Obviously, symmetry is a good one. I also do the knee iso push, and then what I'll do is I'll do a ratio between the ankle iso score and the knee iso score. And Valve's actually put out in their practitioner guide kind of an ideal ratio that you would want that to be within, and it's between 0.7 and 0.8. So basically, if you're below 0.7, you want a little bit more ankle strength. And if you're above 8, you actually want a little bit more knee strength to try and just balance out that co-coordination between the two joints. So that's one where, kind of circling back to isometrics, like I use them in the very beginning, but then they absolutely have a purpose later on, just to kind of help me with some of those return to training decisions. So there's that one that I'll do. Obviously, like counter movement jumps, drop jumps, whether that's double leg or single leg. RSI is a super valuable metric that we use in that kind of, tendon stiffness and their ability to kind of rebound off the floor. So literature again supports a double leg drop jump value of over 1.3. And if it's a single leg, we want to see over 0.5. So those are pretty well documented in the literature that I also use and have seen really good outcomes with. And then another test that we'll do, not don't have as much data on it, but I'll do like a horizontal land. So where they'll actually jump horizontally and then land on the plate from more of a horizontal vector. And then I'll also do like the single leg land and hold. So just off of a kind of set height and not necessarily jump, but just like land and kind of what does that force trace look like? And oftentimes that's one where I'm comparing the physical trace, not necessarily the values, but looking at, okay, how willing are they willing, or sorry, how ready are they able to kind of decelerate or kind of eccentrically load through that limb? Is it jerky? Is it smooth? Do we see the shapes that we should be seeing in that type of trace? So something that one of my mentors, Travis Godet, who owns Orca here, is really big on is, yes, the values and the metrics from these force curves are really important, but the curve itself, I think, especially within rehab, how that athlete chooses to get there is just as important, because they might achieve a really good number, but if they did it in a way that just isn't safe or doesn't look good or is compensating heavily, we got to nip that in the bud, or that outcome's not going to be as good in theory. So those are kind of some of the tests that I will use. And then sometimes I'll add or subtract just based on the sport or the requirements of that patient. Sometimes I'm doing more endurance or fatigue tests. I know with my tactical athletes, like that's a massive one because sometimes they're in, body weight in excess of 75 pounds with all their gear on and they're rucking for hours. And that's a ton of load on that Achilles tendon. That's very different than what we might see in like, a wide receiver playing football. So that's where, again, like I might change some of those metrics, but the ones I kind of just discussed are some of my kind of non-negotiables that I always implement when we're in that kind of 5 to 6 month phase if we're thinking of a proper return to sport.
Nice, nice. There's one test I find it really interesting is like you said, horizontal jump and land. Why
Mhm.
horizontal jump and land?
Yeah, so this is actually a new one that I've just in the last couple months started to look at. And I think part of that has to do with some of the research coming out of Aspetar. And so it's specific to ACLs. And it basically, I'm not sure if you've seen it, but there's a graph that basically looks at propulsion and landing. And they divided it hip, knee, and ankle. I can never, I'm doing this wonderful gal such a disservice by I can't pronounce her name very well, but I have it and I'll make sure I send it to you. So we're giving her credit. But wonderful Greek gal. And I can't believe I can't remember how to pronounce her last name, but basically she shows what hip, knee, and ankle are doing in propulsion and landing. And obviously, knee specific with ACLs is a little bit different compared to the ankle, but there's so much force in the propulsion and landing at the ankle from a horizontal versus a vertical vector. So it is something I just like to look at. And again, I'm kind of at my point just looking a little bit more at that force curve and what it looks like, not necessarily the metrics associated with it, because some of our athletes do really well in that vertical vector. Obviously, there's a lot more data to support that as well, but sometimes you get them landing from a horizontal jump, and the vector does not look good. They're not yielding as well. They're not getting as low. Their posture, if you film it, might look horrendous. And so these are some of the things that I've recently just started to look at with the help of some of my team here at Orca. They have a little bit more data to help kind of round out those decisions. But that is an interesting one. And I think a little bit more important with respect to the knees that we treat. But I've started to utilize it a little bit with ankles as well, specifically for our Achilles.
Nice, nice. I like it. So I
Mm-hmm.
guess last question before I let you go, and it's probably, I guess probably the hardest. So a lot
Let's
of
try.
so a lot of Achilles tendon tear, a lot of Achilles like rupture, right? So I don't want, yeah, yeah. I'm just gonna ask it. So is there a way, like, or how can we train it to like some sort of like prevent it? Not because you can't really prevent it, but like,
Yeah.
yeah.
Yeah, that's tough, right? Like I think we're probably thinking the same with like, ACLs and like other injuries. Like I don't believe in true pure injury risk kind of negation. I think you can mitigate them as best you can. I think with Achilles, as I alluded to in the very beginning, what's so tricky is that almost all Achilles ruptures have zero symptomology beforehand. So, some of the research kind of suggests that there's a level of inhibition that symptomatic calf or Achilles pain patients exhibit, which ultimately reduces the amount of force kind of going through or accruing through that tendon, which might actually be protective long run, right? Which seems kind of backwards because I think a lot of people would assume, oh, well, I have this really tendinotic Achilles, it's more likely to rupture, but it's not actually what we see, and so far isn't really supported. So it's a tricky one, and I don't know if there is an answer. I think the way I see it is maybe a bit more specific to our general population who my question to them is, what are the activities that they either are doing or want to continue doing or want to take up? And are these activities, when we think of the Achilles and the calf specifically, do they have a capacity to withstand something like that? And a lot of times they don't. That doesn't mean they're going to get injured, but if we can kind of bridge that gap by giving them, a really well-rounded, protocol, or program, whether that's maybe they just need a bit of strength, like maybe they do need to do a bit more endurance, maybe they haven't jumped in a long time and we need to kind of reintroduce them to that plyometric continuum. That's kind of the way I handle those ones in clinic. If I'm being honest, I think it's harder to prehab or mitigate some of our tactical and our pro athletes because in theory these guys are as fit as they can be, and their training already encompasses a lot of these portions, a lot of these ideas and concepts. So I mean, I think it's something where, if you have access to tech and you're able to kind of do more monitoring with them, whether that's preseason, throughout the season, postseason, that kind of a thing, that might be a value. And it's something that I'm actually working on with some of my tactical athletes right now, as I'm actually doing a bit more of like a let's fatigue test you kind of periodically, kind of based on like the shift in the volume that you do at work and kind of what toll that takes on your body and what does that translate into kind of function and rehab. So I'm doing a little bit of a project on that right now. And so I think if you have the ability to kind of track these people, great. Maybe we get some more info. I know I'm looking to a lot of the research and seeing if there's ways and protocols that can prevent. But I think like any other injury, like just give yourself as much, functional strength, functional range. Don't be afraid of the fast movements and train them. If you're going to be fast, make sure you train your brakes, make sure you know how to slow yourself down and doing it well. That's kind of the approach I take. It's so general, but I think that's just where we're at. And until we kind of get a better idea of maybe why these Achilles tears are so prominent, and if there is kind of one mechanism that drives it, that's probably going to be our solution. But I don't have an answer for you, unfortunately.
No, I
I'm a little
good.
bit more general of let's just train everybody to be a little bit more well-rounded, and hopefully that's the answer.
Yeah, that's probably where we at right now because it's probably the hardest question.
Oh, I
And if
know, I
yeah,
know.
if anyone figured that out, it's probably gonna be a billionaire.
I'm like, run with it. That'd be great. Kudos to them. It probably won't be me, but I'll happily read that report and I'll have my thoughts on it. So
Nice. So,
awesome.
uh, for those who are interested in what we're talking about today, where can they reach out to you and where can they find the ebook?
Yeah, so I don't have an ebook, but the kind of case study that I referenced a lot
Yeah.
today was accessible just on Valid Health. So Valid Health has kind of an online blog where they kind of follow different case studies and how we utilize their tech throughout that process. Otherwise, you can find me. I've got an Instagram page. I don't post very often though. Definitely not one of my strengths, but I do post interesting cases when I have them. And I'm always open to just, DMs and reaching out to people if they have questions, that kind of a thing. So
Nice, nice.
thanks, Eric.
Thank you.